And after we'll talk about randomized controlled trials, right? So that's the topic for today that we're speaking about, right? So what we'll go through is we'll say a little bit about what evidence-based medicine is. We'll classify this thing called the hierarchy of evidence. We'll outline evidence-based practice. We'll look at how we create an answerable question, right? So again, the use maybe not so specific to family medicine or emergency medicine, they're kind of broad, but this is what we say. The first thing I usually say about this topic is when we practice as physicians, all of us here are practicing physicians. We practice in varied fields. I'm happy we have two different specialties related but different specialties in the room today. So what our specialty is, we really do the same thing. It's the same thing we do really when we see patients every day. We diagnose and treat, exactly. So we just diagnose and treat people. At least that's what we do as doctors. Sure, we put on other rules here, but that is the main thing. So the usual thing I would say is we diagnose, we treat disease. So EBM, evidence-based medicine, for everybody, right? It's unfortunate, I would say, that all the people in this room are the only people in this room and this faculty that does this course. None of the other clinical specialties do courses. This is not a family medicine or emergency medicine. It's a everybody doctors thing, right? Oh yeah, we just hear a phone ring. So I mean, just mute your mics unless you want to speak or say something, right? Thanks. So evidence-based medicine is for everybody. So I mean, I think it's a topic that all doctors should be exposed to. If you're doing cardiology, if you're doing general surgery, if you're doing anything. But so far, it is only emergency medicine and family medicine, right? So EBM is for everybody. I usually start with a case vignette. It's not something that it's just a case. I use it as a teaching point. And there's a lady who actually visited me, her GP, her doctor. I didn't change this case probably from when I speak about this with my undergrads. So if it have any undergrads in the room who I would have taught, and I know it have undergrads in this room who I would have taught, right? Because since 2012, I've seen faces that I know. The case should be vaguely familiar if you came to the class when I did it there. So it's an obese lady, she has hypertension and arthritis in her knees, and she come and she asked me this question. She said, Doc, I want an injection for weight loss. So what would be your reaction to this if a patient come and asks you a question like that? Anybody? What do you think? We're going through your mind. All right. All right. Okay. So you're convinced. You say, well, hey, there's no simple thing. There's no quick fix. So the patient said, Doc, I try all of that, all that too hard, and I do tell me about the injection.
Well, which part did you hear about this injection?
She heard about the injection in the Express newspaper the weekend before. This is the article the lady print and bring. It was centerfold in the Sunday Express the weekend before, and that is why she bring it. Right, so for you guys who are not online, who are not hearing what Vishma is saying in class, she will say, hold off on this, what you see in the article for now, and we have to slow down. We don't trust these things showing here. But this lady actually brought this article and she showed it to me. So she's like, well, look, other people, you don't know about this injection, look, other people showing me there's an injection for weight loss. And from the name, you could probably tell who it is. A sure way to fight fat, right? So sure way, yeah, sure way. So this plan that this person involves HCG, the hormone HCG injections, and a diet. So they put these people on these HCG injections. Look, you see this picture, graphic picture where they injecting this person, I suppose, in the abdomen, and they also give the person, I know it's scary, they also give the person a 300 and a 500 calorie per day diet. There's one snack. Cindy says there's one snack. One snack is 300 calories. Wow. You have some caloric rich snacks there, man. Peter brings snacks, right? On a Friday evening for us to go through this, right? So, I mean, if you see something like this, what do you think happening? Why do you think this person will lose weight? Yes, because they're on like borderline starvation, exactly. So just keep that in mind. This person getting this injection, and again, results they're losing weight, but it's not because of the injection, it's because of the low calories. So just keep that in mind. So it continues. So people essentially pay these people thousands of dollars to get repeated injections. And look at the weight loss the article is reporting, 42, 32 pounds in like 3 weeks. So, I mean, a person seeing this will be enticed. They'll say, but I didn't think for me. Doctor say I had to lose like 40 pounds. It sounds like the right thing, right? So with this information now that the patient showing you, if you show you this, right, and you say, oh, doc will tell me, oh, I really want to try this injection thing. Look at what the paper's saying. Seems as though it's true. Okay, all right, yes. Right, so Bishma will tell us if she wants to go ahead and starve herself, pay her money to starve herself, go ahead and do it. Fair enough statement, fair enough statement. What do you think might happen to these patients in reality? Even if they go and try it, what do you think will happen? They lose weight and they gain it back. Yeah, that's right, definitely, right? So they lose the weight and they gain it back. Lots of people go through these kind of fat diets and these things even before carnival. I see people put on 20 pounds for Christmas and then they lose 30. And then they gain back 40 after. So, I mean, yeah. So, of course, weight loss, we're interested in long term, right? If you lose weight in long term, right? So, I mean, that's just an example. Because when this lady asked me this, they didn't teach me about HCG and weight loss in medical school. I never had a class on that. So, when she showed me this article, I had to think, well, could there be any truth in what this lady is saying? Vishma already decided no. But could there be any truth in what this lady is saying? You never see a pregnant woman lose weight. Good rationing, right? Good thinking. So, I mean, I think the idea behind it is in pregnancy, the HCG has to redistribute weight and calories for the baby, you know? So I think that was the thinking behind it. So what I have to do now is practice evidence-based medicine. I have to go and look up the research to see if there's any truth in what this lady is saying. And I have to come back and give her an answer. So I told the lady, I don't know. It seems kind of suspect. I wouldn't go to it immediately off the bat. So this is what I had to do. I just showing some more scenarios just to stimulate thought. That was just one example. Is rosuvastatin better than atorvastatin in preventing MIs and stroke? So if a person never had a heart attack and stroke before, and they said, doc, cholesterol high, or my doctor tell me I should be on a cholesterol pill, which is the best? How we know? Which one you'll say is best? Which one you'll give? Crestor or Lipitor? Primary prevention heart disease. This question has been asked and answered. What you all prescribe? You'll prescribe the one not on the slide, simvastatin on CDAP. Right? Because that's what everybody have free, right? Or yeah, to the evidence-based medicine to see. So I throw these up, of course. I mean, I'm not probably going to give the exact or correct answer, but these questions have been answered in medical literature already, right? What's the best way to diagnose fibromyalgia? You'll ever diagnose a patient with fibromyalgia?
I think it's underdiagnosed.
You think it's underdiagnosed? So how do we diagnose it? By exclusion. Okay, so there's no criteria you could use, say, all right, or tests you could do that will say, yes. Pressure points. That's right. Okay, all right. A lady was diagnosed with stage 4 metastatic breast cancer, and she wants to know, well, doctor, tell me how long I have to live? What factors will influence her prognosis? I've had patients ask me these kind of questions. And if a patient ever asks you, so doc, what really cause pressure? What really cause hypertension? You say, well, smoking and salt and nothing. He said, but I do none of them things. And I said, oh, hypertension. So then he's like, well, I don't know, everything idiopathic. Right? Everything in medicine is idiopathic. We don't know the cause of anything. Right? If you ask a doctor, but what caused this to happen? You have no clue. Just say a patient, she had some lump epidermolysis. That's what really caused them things. Say, I really don't know. You know, we really don't know. But the reason I put these 4 things up is these are the 4 things we do as physicians. We always want to know what's the best treatment. We always want to know how best to diagnose a condition. Sometimes we want to know about prognosis. If a patient have X, Y, and Z, what's going to happen to them. Or sometimes we want to know what has caused things to happen. So these are the big things we do as physicians: treatment, diagnosis, prognosis, and etiology. And that's really what this course is about. This is a long-winded definition. You don't have to memorize it. The definition just describes what evidence-based medicine is. So it's the process of lifelong self-directed learning in which you care for patients, make you want to search for information to give them information about what we do as doctors: treatment, prognosis, therapy. To a certain extent, I suppose all of us in this room practice evidence-based medicine to a certain extent. If a patient came and ever asked you a question and you didn't know the answer off the top of your head, and you say, well, let me go and look it up. You look it up right there in front of the patient. You pull out your phone, you check something on Medscape or up to date, and you tell the patient, yeah, that treatment is working. Yeah, we could use that for you. You have practice evidence. certain extent. So it's something that we do along our careers. It's not something you only do in this course, it's something you continue to do as practicing physician. First step in EBM is asking an answerable question. And we ask this question in the format PICO, P-I-C-O. So what's PICO? P is the patient, I is the intervention, O is the outcome. So the patient is what kind of patient we're looking at. The I is what treatment considering given them, was the comparison, was the outcome. So there's an example. 18-year-old girl had exposure to chickenpox. She wanted to know if getting the vaccine compared to not getting any vaccine would prevent chickenpox from coming on. This is a question, I suppose, about prevention, but it could also be a question about treatment. If we had to ask a question about treatment with the obese patient with HCG, we can ask in an obese patient, does HCG compare to what? What do you want to compare to? Lifestyle changes, plain old diet and exercise, weight loss. That's so, or we could ask if a person has peptic ulcer disease, if they have an epigastric pain, does giving them PPIs versus triple therapy lead to better resolution of the symptoms if the person is H. pylori positive. So this is what PICO looks like. And anytime you're thinking about treatment, you're really asking yourself a PICO question, right? So we'll see this come up on about drug, right? So we could formulate PICO questions for treatment, diagnosis, prognosis, and etiology. We'll be talking and next week about treatment, right? And then we'll do diagnosis, prognosis, etiology in that order for the other 5 weeks. Question?
I was wondering how to do a PICO for etiology. Like, what do you compare?
Yeah.
I couldn't hear it.
Yeah.
So
yeah.
this is later now.
Yeah. So I was about to say if you can't wait for the 5th week, right? If you really can't wait for the 5th week, the outcome is easy. Is what went to outcome. The I and the C are the risk factors. So in an adult, the smoking versus no smoking lead to the outcome of lung cancer, right? So we'll come back to it again, definitely, and we'll see it, right? But PICO essentially remains the same, right? So we're talking about treatment this week and next week, and we'll go through all the others. Let's find an appropriate paper. If I tell you go and find a paper, find research on HCG and weight loss, what are you going to do? PubMed, right? So these guys now had the library session, so hopefully they had plenty to talk about PubMed. Emergency medicine guys, you all do literature searching as part of your work or any of your courses or anything? Yeah? What you all would use to search for? Up to date, right? So looking at up to date would be a great source if you want to find something. I could tell you probably, I will save you the trouble and tell you if you look for HCG on obesity on up to date, you're going to find 0. And there's a reason probably why you're not going to find anything, right? So you might find a journal paper on up to date, although the references and up to date articles are based. People who write up-to-date articles are people who read the literature, write the articles based on research, right? That's what they do. They save us the trouble having to do that. But the other place you can look apart from PubMed is Google Scholar. There's the other place that you could use. The other place you could use is what? Google. When you Google something, what you get? Wikipedia, that's your first hit. What's the next hit you get? Medscape, usually you'll get Medscape or eMedicine. Maybe you might get up-to-date. It's got other strange things really not of interest. And babycenter.com and you know these things depending on what your search is. So to make the search relevant, to make it medical, instead of just doing Google, scholar.google.com. Right? So if we had to search for an appropriate paper, I'll just come out to presenter view for this and see. And I'm just going to go to a browser to see if we could, no, not Zoom, if we could actually go PubMed. All right, so you guys on the other end online, are you all seeing the browser screen? Okay, excellent. I see you shaking your heads. Great. So if we had to search for an article to see HCG could lead to weight loss, I'm PubMed. Tell me what to type. HCG, very good, very, very good. HCG. You could go to advanced and put in your filters. Yeah, I know they teach you all them fancy things, right? So we could do that. You're most correct. Type HCG. What are you interested in? Weight loss. So what to do? Hit enter. See what happened? Fair enough. Fair enough. HCG and weight loss. Fair enough. So look at here. We find how much? 125 articles. You think all these articles are relevant to what we want to look at? No. How we could filter it and make it smaller? How we could find articles of interest or relevant? So it's one of these simple things we could do. You could use the Boolean filters and things together. So you could use those. What I find is very helpful is to use these filters right here on the side. So look at it, 125. If I click human, it would exclude all the animal research. How much you think is animal research out of 125? All right, let me see. 76, almost 50. See? So now we're looking at only things with humans. The other way we could filter this, the reason we get all these articles, because all these articles have the word HCG and weight loss anywhere in the article. The other way I find useful sometimes to limit a filter is you only want those words if it's probably present in the abstract. Because if you're looking at the article and it was talking about weight loss and HCG, at least all those words should be mentioned in the abstract. So how you could do that is to show additional filters, search fields, right? When you show that, it pops up here, right? And then when you click on this, you could limit it to either title or abstract. So let me just limit it to the title and let me see what happens. So if we click limit to title, we're looking for only articles with the word HCG and weight loss in the title. And look at it, from 76, we have gone to 4. Now, it could be in doing that we may have excluded some articles of interest. So if we had to look at articles that the words appeared only in the title and abstract, then we would say apply, and then it would get a little bit broader, 67, sorry. And if what we're going to talk about today, the study type that tells us if any treatment works, we know it would be a trial or a randomized controlled trial. So if you want to only look at trials, all I would do is just click on trial. And when I do that, it would limit it to 6 articles, some of which may not necessarily be necessary, right? I mean, look at this one, management of unruptured ectopic gestation by linear self-endoscopy. That don't look like it has anything to do with HCG and weight loss. Maybe this the treatment of obesity, right? So I just did that, especially emergency medicine people. I know our guys did that in the library last week. Just to show you briefly how you'd search. And when you search for articles, you're going to find a whole set of stuff, right? So that's how you would find an appropriate paper, right? That's how we find an appropriate paper. Now, all these articles we found, if we look at the 76 articles we just found, you could categorize them. You could put them into several categories. And this category that is the hierarchy of evidence. So the hierarchy of evidence essentially says that when we find research articles, they can be put into several categories. And these categories could be ranked based on how strong the evidence is. So the study that carries the greatest strength in medicine is called a systematic review. A systematic review is the strongest body of research you could ever get, like ever. And we'll understand why next week, because that's what we'll talk about next week. But second one on this list is your randomized control trial. A randomized control trial is right almost up there, telling us in terms of the strength of evidence. This tells us the best way to treat disease. Then there are also cohort studies. Cohort studies, as we'll see in the 3rd week, tells us about prognosis. Then there are case control studies, which we'll see in the 5th week, that tells us about etiology, what causes something. And there are other, there's case series and case reports. Anyone have any idea what's a case series or case report? Sure, you all have probably come across a case. Anyone ever read a case report before? Yeah, yeah. Any of you guys, emergency medicine guys, you all did any writing of any case reports as yet? Or you have an interesting case. You write it up, right? So I had this patient that came to me 3 years ago, 37-year-old fellow with headache. Headache just got worse in the last week. He had a history of headache before and he was always taking painkillers like for years. When I initially showed him, I actually thought it was medication-induced headache, but the headache got worse. He developed red flags, severe, not relieved by medication or rest. It was really, really horrible. And he ended up getting neuroimaging, and the CT scan suggested that he had multiple metastases in the cerebellum, which is kind of strange. I mean, when you see mets in the brain, it's usually cerebral hemispheres you get mets. You would only see mets only in the cerebellum. Of course, the CT recommend MRI. The CT also showed that he had hydrocephalus. And the MRI, the radiologist made the diagnosis. The radiologist said these lesions in the cerebellum are in keeping with hemangioblastomas. You all ever heard about that? I never heard about hemangioblastomas before. So I had to go and look it up and see what this thing is. And this condition is typical of von Hippel-Lindau syndrome, right? So VHL, you read about them thing in the textbook, we see them populations. We don't see those things locally, right? So I'll publish it with the neurosurgeon and the geneticist who confirm the condition. VHL are going to publish and write it up. So that'll be a case report. It don't mean that it's a common thing to see every day. It's rare. Nobody in the family had this, so they think is a mutation, and the mutation rate is 1 in 4.4 million. So I mean, yeah. So he didn't get it because he had a normal gene. So you have to do a whole set of specific screenings because these conditions is risk for certain tumors, and he also has a condition called Lynch syndrome. Lynch syndrome increases the risk of certain bowel malignancies, right? Certain things. So case reports, strength of evidence low, but they're good because they build interest in the doctors. Now, what we see in these cases in the Caribbean, not so uncommon things. They got to read about, but the strength of evidence from a case report is really low. A case series would be one. A case report is one case, so a case series would be several cases. So if someone's in pediatric, several cases of Kawasaki's disease, you all ever saw Kawasaki's disease? Yeah, when I was an undergraduate medical student, for some strange reason, they had several cases coming in my pediatric rotation. I remember this in junior year. And all the consultants would be like, well, we do see this often, you know, go and check this out, read about it. So if someone were to write up, you know, 10 cases of Kawasaki's disease seen in Trinidad, that would be a case. Again, strength of evidence, not so great, but it raises interest. It lets us know we have. Some people write things like editorials, opinions, ideas, and you could bet these are very subjective. Kind of like a newspaper article, people could write and say anything, right? It is always surprising. It happens every year. It always comes up with vaccines, right? So it always comes up something with vaccines. And once I saw someone publish this thing in the newspaper, and who it was, other faculties, and not the faculty of medical sciences, right? It was the dean of one of the other faculties. Vaccines, and they were saying this and that, and I was like, well, we have to respond. We have to respond to this thing. These people propagate a whole set of things and misinformation about vaccines. You would think if any faculty write about vaccines in the newspaper is MedSci, you know? So it's just that people write the ideas and editorials and opinions, and just like a newspaper article editorial, it is opinionative. It's not often based on fact. Sometimes it's based on people's emotion, what they feel, what they want, the message they want to get out. Animal research, as we saw just now, sometimes you search for things, and a lot of things they get is animal research. We saw how we could filter it out. And this one that kind of hidden below here is in vitro research. Sometimes they get an article, cure for cancer soon, or patient cured, or cure for cancer, some kind of fancy thing, and you read about it and there's nothing in a patient. It's something that they do in some lab, in some cell culture with cancer cells, you know, you get excited and it's like, all right. It's not bad. Eventually people realize these things, right? So keep in mind when you find an article, when you do your search, ask yourself, which type of article this is I find? Is it something on animal research? Is it an editorial opinion? Or is it a systematic review or trial? The reason you need to know this is because the strength of evidence that comes for them changes as we go down the hierarchy, right? So keep this in mind. If you have to do a search, I know this slide is small, difficult to read. This essentially says where you could look. You could look at what we call, we'll talk about that next week. You could search existing databases. You could do PubMed. You could do Google Scholar searches, right? This is what this is just describing. Next step, you find an article now. Suppose we looked at that article that looked at obesity treatment in HCG from 1977. You would find the article and then you will say, well, the article, suppose the article recommended, say, yes, this thing is good. I'm not saying that it does. It don't mean you can't take the conclusion that it's practice medicine. Anybody could say anything. So you can't just simply take the conclusion that any journal article and practice medicine. Disappointing news. Only 1% of the medical literature is done perfect, well, and ideal. 1%. Disappointing news. So it means anything you read, statistically speaking, most of what you read flawed or have some bias or have something wrong with it. Threats to validity, as we'll see. So what this means is when you find an article, you can't just take what the articles say, you should appraise it. When we appraise the article, you all will be doing appraisals for the rest of this, at least for the next 4 weeks. You'll ask these questions, right? So I'll give you all certain articles, as you'll see the ones assigned for RCT. You have that paper, you look at the paper and you're just asking yourself some questions about the paper, and there's a checklist to guide you, right? So at the top you'll see the checklist and the paper that the groups are assigned to. And these are the questions you'll be answering. Did they ask a clear question? Was a clear PICO asked? Are the results valid? Are they important? Can we apply this to our patient? So we ask doctors for this thing, which is a very important exercise. Not so much for pharma people, but I know you guys, emergency med, have to do case reports. You'll have to do case reports, and sometimes in doing case reports, you have to appraise literature, right? So it will come in handy, especially for you guys as well. So you appraise the article, and what you do, you'll come up with some kind of answer. So the article says, yes, you could give your patient this treatment, but what you have to do, you still can't give it to your patient. You have to consider your patient values and preferences. Put this up on the EBM Moodle online, because what we do as doctors generally is we make decisions. At the end of the day, that is what we do. We're either going to admit the patient or discharge them. Either going to transfer them to Mount Up Emergency, we're going to send them home. You're either going to give the patient aspirin, you're not going to give the patient aspirin. At the end of the day, the decisions we make are black and white. But three things guide our decision. One is the best available evidence. What the research and what the guidelines tell us we should be doing, right? The other, patient values and preferences. So what the patient prefer and want. So sometimes best practice we can't do because our patients say no. I might tell a patient, well, everyone over the age of 50 should be screened for colon cancer. Patients say, well, what kind of test? What I have to do for that? So one of the tests you could do is a colonoscopy. It's expensive. You have to do bowel prep. If you have to get done in hospital, it's like $5,000 to do a colonoscopy. But the patient say, well, doc, you know, that expensive. I have insurance. How do I do this test? Well, if the patient say, doc, yeah, I have insurance. I go do this. That sounds scary. I think take a bowel prep. You have to put a tube camera inside. You sedate me and put me to sleep for this thing. Patient might say, no, I don't want that done. So then they might opt to do something cheaper or something less invasive, like a FIT or, you know, FOBT, whatever stool test. So sometimes what our patients prefer also determine what we do for them. And the other one, doctor judgment. This is doctor judgment slash you could put onto this resources available. Meaning sometimes we can't practice. Sometimes our patients say, yeah, like guidelines tell us, yes, you should do that. And then we can't do it as a doctor because it's not available. Patient come in with a STEMI, right? Gold standard treatment for STEMI is PCI. Tell the patient that, but then patient again no PCI. Why the patient again no PCI? Because they present a facility where PCI is not even available, or even if you have to go transfer them, by the time they reach in the next one, they're outside the time window period or whatever the reason. So sometimes we can't. It's because we don't have the resources. So we have to use our own judgment and decide, well, what's the next best thing I could do for this patient. So remember, these are the three things that determine what we do as doctors. You know, resources, which influence our judgment, what the evidence tells us, and what patients' values are. What we'll be talking about for this course really is how we figure out what's the best available evidence. The last thing we do is assessing what we have done. And we do this through something called the audit. So the audit really is a cycle. I wouldn't say much again about it because actually do an audit for a chronic disease module between year 1 and year 2 next year. Emergency medicine people still do an audit. They did audits in the past because I used to mark them. I'm not sure if they're still doing them anymore, but I think not. But it's a very good exercise because audits become part of your working lives. I don't know if you all ever participated in audits as part of your work. An audit is essentially a way to see if we keep up with best practice. So best practice might mean I would use an emergency. A person presenting with acute chest pain in emergency should have an ECG done within 20 minutes. So that's the rule. So that's the guideline. So you might say, well, I wonder how my emergency doing. You go, you look at 100 people presenting with acute chest pain and you see, well, 30 of them get the ECG within 20 minutes. The other 70 didn't. You say, well, why is this? Why is we falling short of the guideline? And then you try to do something to make that better. You buy more ECG machine. You train more people to do the ECG. You remind the nurse and even doing chest as soon as they come in, you stick it up on the wall, big. And then 3 months later, you go and collect it again. And 3 months later, you say, well, out of 100 people now, 60 of them got the ECGs within the time. So you're not there, but you're doing better. What you have done in that process, what I've just described is called an audit. It's a cycle. An audit is simply a tool to make sure we follow in best practice, right? So just keep in mind an audit. So, as I say, coming soon, right? So audits. So what that brings us to is this thing called the randomized controlled trial. And the randomized controlled trial is the study that we use to tell us how to treat any condition. We said just I want to ask you all what we do as doctors, or they say we diagnose and we treat. So to treat, how you know how was the treatment for a condition? What you do? Patient come with cellulitis. How you know how to treat them? How you know that? You take a history, right. But how you know what treatment to give them? How you know is the treatment of cellulitis? How we know that? Antibiotics, right? It's not your question, no. It's antibiotics, everybody quiet, you know, like, is there a treatment of cellulitis we don't know about? Antibiotics, how we know antibiotics work? You learn that in medical school. The teacher at your seat in surgery, and anytime a patient comes and tell you reflex to prescribe antibiotics for them. If you had to look up some treatment of a condition and you didn't know what was the treatment for a condition, if I asked you was the treatment of von Hippel-Lindau syndrome as a condition was when I saw that patient, how you'd figure it out? How you'd know was the best way to treat that patient? Where you would look? You would research, so where you look? Where you look? You look e-medicine, you put up the up-to-date article, you would see, you would open a textbook maybe, look to the go and where you jump forward to the treatment section. In e-medicine, it nicely laid out, history, diagnosis, treatment, right? So you just click treatment, and that's how you'd find the information. The treatment section and all these sources and up-to-date and textbook, wherever the consultant teach you, how we know it works is because somebody at some point in time did a randomized control trial. So we know antibiotics, when you think about it, we know antibiotics work for cellulitis because at some point in time, someone did a RCT to know that it actually works. Right? So anytime you're thinking about treatment or prevention, think RCT is what gives us the answer. So this is what we look at, right? We look at how we do a PICO for treatment. We'll actually appraise our RCT next week, right? In groups. And this is really what we look at. The major elements of our RCT. We'll see how it's analyzed and how we interpret the findings, right? So if you all had to guess, when was the first controlled trial done? Better guess when that is. When do you think that is? Better guess. I know some people have it printed out, so they probably see it. But ones who don't have it in front of them, if you had to guess like when the first trial was done, when do you think it was done? Guess. You might guess a year. What do you say? What do you say? What do you say? 1800s? What do you say? 18? I heard 18. 1821? Wow, that was specific, boy. You all know something happened then. Enlighten me. Tell me what happened in 1821. I don't know what happened in 1821. So from the looks of this guy, if you tell is old, right? It's many, many years ago. And this was what he published. So this is Dr. James Lynn. I actually published this in 1757. He looked at the treatment of scurvy. So what he found is people had scurvy then with the transatlantic flights and again fruits and whatever, vitamin C. So he took 12 sailors with scurvy. He break them up into 6 pairs. The first pair, he gave them seawater to drink. Give them sulfuric acid. I know, scary. The third group, he gave them limes. The fourth group, he gave them something else. He gave each one of the. And what he found, of course, and the people who got the limes, they got significantly better. The scurvy was almost cured, while the other 5 pairs still suffering and almost sick. So it wasn't a randomized controlled trial, but it was a controlled trial in the sense that he had the thinking to give everybody with the same condition different treatments and see if people are going to get better. And the whole idea from a randomized controlled trial actually springs from that. So I don't know if it really was the first controlled trial done, but it's good to know historic tried before and where it originated. So this is actually where it probably originated. So what is a RCT? What does a randomized controlled trial do? What it does, it takes a group of people who could have a condition, it randomly assigns them to a treatment or to a control group, it follows them up, and then it goes to see if people get better, if they improve. That is really what a randomized controlled trial. That's the basic structure, right? So we'll see what randomized mean. Right? It doesn't mean that, right? But in terms of if we go back again to history and we look, see when was the first published randomized controlled trial, it was in the year 1940, relatively recently, right? So it's only over the last 70 years or so that people actually actively publish in randomized controlled trials. And when I tried to search for it actually last night to update this presentation, if you search PubMed, there has been almost 500,000 randomized controlled trials. Not done, because a lot of them that are done are not published, right? So there are so many, right? Look at that, 500,000. And the first one was published in the year 1948. So imagine that, 500,000 randomized controlled trials have been done in the last 70 years. Why we do so much? Because we want to know how to treat, right? We want to, right? You hear about these guys from before, Sir Austin Bradford Hill and Sir Richard Doll. These are they published was streptomycin in treatment of TB. So the first randomized control trial was done to see if this antimicrobial could actually help people with tuberculosis. The other way randomized control trials are used is in making guidelines. So these are guidelines for treatment of common cardiology or common heart conditions, right? You all may have heard of some of these studies before, All Heart, Progress. These are old ones, ValHeft, have more recent ones that have come out. And when people talk about all these guidelines, all used now come from studies, and most of these studies are randomized control trials, right? So randomized control trials also form the basis of all the guidelines that we use. Actually, when people write guidelines, what they do is they look for randomized control trials and they write the guidelines based on trials. And we just take the guidelines and we practice medicine. So these are the steps in our RCT. You pick a group of people, you randomize them, you give some people a treatment or a placebo, you look at the outcome and you do an analysis. This is the of a randomized controlled trial in terms of how it works. So we'll go through the steps. So the first step is to pick the group of people you're interested in. So if you have to pick a group of people, what kind of people you would pick? The answers will depend on what is your people, will depend on the question you're trying to answer. If you go back to the obesity and HCG example, if you want to do a trial seeing if HCG compared to diet and exercise make people lose weight, what kind of people you want to test it on? Fat people. Fair enough, obese people. So you would get a group of people, and how you define that obesity? What you'll see? BMI. So you would say, I only going to pick people with a BMI more than 30. That's right. So you'll get people with a BMI 130. Where you will get these people from? All over the place. Yeah, you could get people with a big BMI all over the place. They don't necessarily have to come from a health center. They could come from community dwelling. They come from hospital. They come from all over. But this influences where. Usually, you would specify inclusion and exclusion criteria. Inclusion criteria is the people you want to include in your study. Exclusion criteria, and some of my postgrad students, even when they're doing the researchers, mix this up. They say inclusion criteria, men. Exclusion criteria, women. Right? So that is not exclusion criteria. Exclusion criteria is understood if it's inclusion criteria, men, you exclude women. Exclusion criteria is the people who your inclusion criteria say including, but you would still want. So if you say the inclusion criteria is men, the exclusion criteria should be if you're looking at men who don't have obesity. You would say, all right, we want to exclude people with a BMI or less than, right? So it's not necessarily mutually exclusive. So usually when you read a trial, the first thing you'll see being described when they pick the people is how they pick the people and what was the criteria, the eligibility criteria, who they included and who they excluded. In a condition like this, if you're testing, we just say HCG and weight loss, you might want to exclude people. So the preparation you want to test. Or you might want to exclude people who have BMI elevated due to like an underlying medical condition, like people who have obesity because they're hypothyroid or something, right? So you always ask, do these criteria make sense, right? That's what you usually do. Well, consecutive patients recruited. Usually when you recruit people into a study, you bring people in one after the next and you ask them, see if they meet the eligibility criteria. If they don't meet the criteria, you don't include them. The next person you bring that meets the criteria, you include them. These considerations affect what we call the external validity or generalizability of a study. When we say external validity, what we're really saying or asking is the people in the study, in the trial, we're asking, were they similar to the patients you see every day in practice? If someone did a randomized controlled trial in Scandinavia, can we apply that to Trinidad? Why you'll say that? How they different? Genetics. All right, fair enough. Weather, the patients differ with respect to weather. I mean exposure to weather. Fair enough, fair enough. Suppose we were looking at treatment of hypertension. We want to see if a drug works. Food-wise, possibly, right? So you always ask, could the patients be different? But not only just simply could it be different, could that difference explain the outcome you're looking at? If you had to see if patients respond to blood pressure medication, it could be because of just human physiology and how the person in Scandinavia respond to blood pressure medicine similar to someone in Trinidad. Or it could be that it might not be. So you always ask, is the trial externally valid? When you treat patients, ask, are the patients you treat in every day similar to the patients that the study came from? And if your knee-jerk reaction is no, the next question should be, well, how are they different? And is that difference, could it explain the outcome you're interested in? Because I could tell you, we haven't done much randomized controlled trials in Trinidad. We use the results of done to treat people, right? It don't make sense repeating all the 500,000 RCTs done over the world just in a Trinidadian population. No one have the time and resources to do that. So what we do is we assume that the findings of other trials are externally valid, and we take the conclusions and apply to our population. Most of the time that is work. Sometimes it doesn't always work, right? So you have to see why. Internal validity, steps 2 to 5, right? Is everything else. Randomization. What's randomization? Randomized controlled trial is named after this process. So what's this thing called randomization? What randomization mean to you all? How we have to describe it? How we describe that? What is it? Lotto? You say lotto is randomization? I think that's a perfect description of randomization, because you'd want to believe they pick the numbers randomly, right? Right? If they pick the numbers randomly, then there's a 1 in I don't know how much chance of winning. So if I had to take a group of 100 people, them up into 2 groups of 50 randomly, how to do that and why I want to do that? To remove bias, fair enough. So in the context of a randomized controlled trial, what we're trying to achieve, we take a group of people with obesity, we split them up into 2 groups. One group we're going to give HCG, the next group we're going to give diet and exercise. What it is we want about both groups before we give them the treatment. To be similar. So that is the key word. I want you all to remember is we want the 2 groups to be similar. Similar before we give them any treatment. Why we want that? So when we give the treatments and we see a difference, we show that the outcome is because of the treatment. And it's not because of the people before. If we had a difference, let me just say one group was older and one group was younger. The older group already set up to get more sick and get more heart attacks and stroke. If you give your treatment to the younger group, and the treatment has no effect, but then the older group, then what will happen? You'll say, but this treatment really working, boy. But the treatment not working. The treatment seems to be working because they give it a group of younger people who are already set up to have less adverse outcomes. The purpose of randomization is to produce 2 groups that are similar. And that is the strength of a randomized control study. The strength in a randomized control trial is this process randomization, which ensures that 2 groups are very similar. So the only difference between the 2 groups is the treatment test. You follow these people up and you see an outcome, you're kind of thinking, well, it's probably working because the treatment we actually give the people, not because of any pre-existing differences. Now, if the group's small, it could occur by chance. So if I give you 20 people and tell you randomize them into 2 groups of 10, suppose I give you 20 persons, 10 boys, 10 girls, and I tell you split them up into 2 groups of 10. It's possible that one group could end up with 80% boys and the other 20% boys. Right? It can happen out of pure chance because they're using such a small number. Right? So keep in mind what also and allows randomization to work well is the number of people that you have in the study. And we'll touch a little bit on that on sample size and calculation to sample size. Not so much calculation of sample size, but why you need to calculate sample size in the 4th week. Concealment or allocation. Concealment or allocation means you are the researcher and you have to which group they're going to go into. Going back to the obesity example, you have to tell your obese patient if they're going to get HCG group or they're going to get the diet and exercise group. But concealment or allocation means when you assign the people, that process of assigning persons should be hidden to you. You should not know. So if I had to do that, if I had to do this research now, and I had to allocate people, I have to give people the treatments, assign them to a group, how I could do it and not know which group I'm putting them in? How to do it? Any ideas? Any thoughts? What's that? Pick from a basket. So I'll pick it from the basket. Oranges, apples, placebo. All right, but then I would know placebo because it's P. So if I pick the P and I give you it, I know you get placebo. So what we could do with the A and the P? We could fold it up or we could put it in an envelope, and what I'm picking is an envelope and I give it to you. So I give you a treatment, you have that in your hand, but I don't know which one you get. Right? So that process is called concealment allocation. It's not blinding, we talk about blinding just now. Concealment allocation means the researcher who's randomizing the persons to the groups does not know which group he put in people in. Because that will eliminate bias on the part of the researcher. He might say, well, as my friend, placebo, put it back, pick a next one. Placebo, pick a next one, treatment, all right, yeah, go in the treatment group now. Right? So it eliminates bias on the part of the researcher. For my DM, I did a randomized right? So I did a randomized control trial testing whether or not a topical treatment could relieve painful diabetic neuropathy. You know, diabetics get burning pains, discomfort in their extremities. So I did a randomized control trial testing whether or not this topical treatment could relieve the nerve pain people get in their extremities. And my big trial was 74 people. Big study, 74 people. Big because it took me 2 years to complete. 2 years, right? That's how long it takes to complete. So you might think, well, that's small study, man. Years, right? So GM for me wasn't 4 years, it was 5 years. So, and in doing our study, the concealment allocation, what we did, we took the treatments, so certain treatments were numbered and certain placebos were numbered, and those numbers went into an envelope. And what we would pick when the patients come, we would just pick the envelope and give it to them. And then when they open the envelope, they see the number, then they go to a nurse and the nurse looks at the number and says, this is your treatment, right? So in other words, the treatment allocation was concealed. When I gave it, they got assigned a treatment. I didn't know if it was placebo or treatment they were getting. We actually got a company actually to manufacture the placebo and the treatments for us, to omit the active ingredient from the topical preparation in Grenada, right? So, and that's actually what they do in trials, right? That's actually what they do in trials. So this is a table that you would see as the very first table in the results of a randomized control trial. This is always table 1. Table 1 is all baseline characteristics. So what it does, it shows you the characteristics of each group. Right now, this actual example was not actually from a randomized control trial. I was just looking on Google Images for a table of baseline characteristics to show you all, and this is just one that come up. But if you look at this, these are two groups of people, a group of patients that's normonatremic and a group of patients that's hyponatremic. Right? So this is clearly not a randomized control trial because you can't randomize a group of people to normal sodium, and you can't randomize a group of, right? But I put it up for the interpretive part of it. So what you notice about both these tables, if I ask you, what do you think about the age of both groups of patients? The average age in this group was 60.9. The average age in this group was 64.7. You find it different? Similar, kinda. So how do you say that's similar? What do you say that's similar based on? You minus it? You say that is only 3.8 difference or 3.7 difference? Plus or minus, give or take. So you can look at it, you know, you can look at it and kind of try to figure it out. But something there tells us that they were not different. We'll see by the end of this presentation, what tells us if two groups are different is a p-value. And if the p-value is less than 0.05, we say there is a significant difference in the groups. So this p-value, is it less than 0.05 or more than 0.05? More. So if it's more, then we assume that the differences are not statistically significant. Are similar. And we want that. In the table of baseline characteristics, we want that the groups are very similar. Remember, that is the whole idea in randomization, to produce two groups that are very similar. So when you look at this table of baseline characteristics in the RCT, you want to see non-significant p-values. You want to see p-values more than 0.05. Because if there's a p-value less than 0.05, and we see this in this example, look at the CRP. The CRP 123, the CRP in this group was 73. You might look at it and say, well, them numbers seem real big, boy. They seem real different, but you can't look at numbers alone and make that determination. You need a p-value. And this p-value is 0.008. Is that less than 0.05? Yeah. So what that tells me is that in this group, the CRP levels were significantly higher compared to this group. Right? I wouldn't go into the details of this because I remember saying this is not a randomized control trial. But the point here, baseline characteristics, you want to see that the groups are similar. You want to see p-values that are non-significant, more than 0.05, right? We'll come back to p-values in a bit. Everybody okay so far? Pauline, any questions, anything? No? No? So a few things could go wrong when you do a randomized control trial, and they all begin with C, right? So crossover, contamination, counter loss to follow-up, and co-intervention. And the one that's not shown on the slide is compliance, right? So we'll see what those mean, right? So these are the things that go wrong in a randomized control trial. So the words kind of self-explanatory to a certain extent. Which one do you think easy to explain? Compliance. So what is compliance? Let me hear. If you take a treatment as recommended, as prescribed, how you will determine in a randomized control trial if a person took the treatment? If they If they say so, so which must say, yeah, so me take your medicine. Kadina shake her head, yes, I take my medicine. You believe, Kadina? If the bottle empty, so they can throw it in the plant or feed the dog. You don't know if the medicine went inside them, but fair enough, you can ask them. You can do TB, you can do dots. That's what you're talking about. Dots. Sit down, watch them take it, check them out and think after, make sure they're all in the tablet. Fair enough. Study, that's what they do. That is what they do. That is what they do. That's how dots works in the. So they have shown, studies have shown that dots increases compliance with TB medicines. So there are a few ways to check compliance. So this is a trick question, right? I'm telling you before it's a trick question. Don't fall for the trick. So you're doing a randomized control trial to see if a new treatment could lower your sugar level. You're testing a new treatment to see if it could lower your sugar level. What you could do to measure compliance with the treatment in this study. Measure the sugar level. So you fall for the trap. Fall for the trap. Why you can't measure the sugar level, Kadina? Or anybody? Why we can't measure? But some people say HbA1c. So why we cannot measure the HbA1c or the sugar level? That is the outcome. You cannot measure the outcome to gauge compliance because you're assuming the medicine works. If a person's sugar is uncontrolled, it could be that it took the medicine, but the medicine is a waste of time. Remember, we do the trial to see if it works. Or the medicine works, but it didn't take no medicine at all. So you can understand why if patients are poorly compliant in a trial, you don't know what to do, you don't know how to analyze them. So that is why poor compliance could invalidate the results of RCT. Usually people would say that they want people to be 80% compliant, at least, for a randomized control trial, right? So don't get mixed up. You can't use the outcome measure to gauge compliance. How else we could gauge compliance? How else we could know if people take the medicine, watch them take it, ask them if they take a self-report. We could do pill counts, assume the medicine missing was in them and nowhere else. What else we could do? That is invade serum levels, most correct. We could do drug levels of the phenytoin or whatever drug to see if the levels in the body high enough. So there are usually ways you could do it. And usually when you do a randomized control trial, you should have some explicit way of knowing if people complied with the therapy. What's the other one you think that could be explained? Crossover. So what crossover would mean? They went across to the next side. Yes, that's right. This one is not a trick. So they went across to the next side and the researchers knew. So the researchers actually intentionally crossed them over. So crossover is when a person switched from one group to the other. They went from placebo to treatment to placebo, and the researcher knew it was happening. Now the question is, why we would want to do that? Why we want to cross a person over from one group to the next group? We already assigned them to a group and we allocated them to the treatment. Why we want to cross them over after? Fair enough, fair enough. So you can actually say, yes, we send people over to the other side, but then they wouldn't send them over to the other side. They have to ethically stop the trial and give everybody the treatment as has happened in the past. Or sometimes it did not happen in the past. You'll probably know of ethical situations where studies show that the treatment worked, but the trial continued, right? So the ethical thing we do is ethical. So if you're seeing an obvious difference, especially if the outcome is death, you know, you have to stop the trial and say, hey, this treatment really making a difference. Everybody has to get the treatment now. So that's the reason, right? If you think the treatment is a waste. But crossover would mean in the context of a trial, that wouldn't be crossover. That would be stopping the study and giving everybody the treatment. Crossover would mean the person crossover and they continue to get the treatment that they crossed over to. That's what crossover would mean. So why do we do that? Okay. All right. So like give my example. And crossover. How do crossover tie in with then with bias on the researcher? Yeah. Important. Yeah. So then you think the rearrangement or crossing over he would somehow bias the results of the study to show that the group he crossing people over to looks better? Possibly. I mean, I could imagine that is how crossover could invalidate the results of a study, but So in this group, 20 people went home. So in this group, how many people went home? 10? Nah, 10 more need to go home again. All right. I suppose they could do that. They actually don't do that. No, they don't do that. Right? But crossover comes in handy if you have small numbers of people and you want to increase the power of the study. So let me just say you have 100 people. You split them up into groups 50 and 50. You want to see if Presto better than Lipitor. Presto, you give the other group Lipitor. You run the study for 4 months, measure people lipid levels, then take them all off the drug for 2 months, and then cross everybody over and now give those patients Presto and Lipitor. So now everybody got Presto, and there's 100 people in that, as opposed to 50. So one of the reasons they use crossover is sometimes to increase the power of a study. Now, of course, when you do that, kind of funny in terms of how you're going to interpret the results, because when the people cross over midway, the cholesterol levels already go and they just get. So crossover could sometimes carry over treatment effects from what the patient got already. You have to use special analytical techniques. That is why crossover could be a threat to the validity of a study. The other way where people could get crossover, apart from increasing study power, is to, if you have a less aggressive arm and a more aggressive arm. Let me just say, you know, have some conditions that there's medical treatment and surgical treatment. What conditions you all know of there's medical treatment and surgical treatment for the same condition? Weight loss, all right, fair enough. Weight loss, yeah. So I never thought it that way, but yeah, weight loss. So medical therapy, we're going to give you medication, we're going to give you that and exercise. If it's really horrible, BMI more than 40, you have comorbidities, then we're going to send you for bariatric, especially if you fail at the initial therapy. That's one. Sometimes there's a less aggressive arm and a more aggressive arm. So back in the day, people used to do things like vagotomy and things for ulcers. You all remember that? So cut the vagus nerve to cure people peptic ulcers. Then came, right? So sometimes you treat a condition and it's medical therapy only until the person develops a complication like pancreatitis that is treated in medical therapy. And then after, maybe if the person develops certain complications, then they have to go on to get surgery done. So it have reasons. Sometimes you might want to cross people over from a less aggressive arm to a more aggressive arm. But regardless of the reason, when you cross a person over, how you analyze them? If you cross a person over from the treatment, how you analyze them? You analyze them. See, how you analyze them as treatment. If you cross a person over from Presto to Lipitor, how you analyze them? You analyze them as Lipitor or you analyze them as Presto? So that is why crossover could be a threat to the validity of your study. And we'll see an answer to that question actually in part just now. Is the other one that easy to figure out? Count, lost the follow-up. So where's that one? It starts off with 100 people. So 50 people run away, they go home, they say they'll come back. So me, I'm coming back in the study now, I'm feeling good with the next experiment on me. I'm feeling good. Right? All they do is taking blood and nothing happening. Right? So the person say, but count, loss to follow-up could threaten the validity of a study because the people who tend to return in a study are the people who feel better. People who tend to say, all right, I'm coming back again, I participated in that. The people who probably didn't get relief. So then how you analyze the people who didn't come back? What do you do with them? Right? So we see the answer to that just now. Which one we left with? Contamination. Any idea what's contamination? Contamination is really treatments get mixed up. If you're in a trial and you have placebo and you have treatment, let me just say a husband and wife team in it, and the wife gets placebo, the husband gets treatment, they look at each other medicine home and say, hey, look, your tablet is looking just like mine, give me yours. So the wife now, who's supposed to get one, get the next one, same thing for the husband, and mix up. But they didn't even know the difference. So in other words, it was unplanned and it was inadvertent. The researcher didn't know. With crossover, the researcher knows. Right? The researcher often is the one who's allowed people to cross over. But with contamination, the treatments got mixed up and they didn't know it happened. Right? They didn't know at all it happened. When I had to get my treatment and placebo, I had to make sure and mark the placebo bottles and the treatment bottles with a mark actually before the labels went on. So if somehow we forgot or got mixed up after with the numbers of the code, then we could actually unwrap it and see that it's a placebo treatment or a treatment, actual treatment. You can imagine the trouble if in the factory they mixed it up. I would have no way of knowing, right? In which case we wouldn't be able to do anything about it. You don't know, it's inadvertent, right? So we missing any? We got all? Co-intervention. Co-intervention is what? What word suggests? Co-intervention means they get other things on the side. So you're doing a trial with HCG, these people get an injection, these people not getting an injection, or they get And guess what? The people on the HCG injection also conveniently getting, or not getting, a 300-calorie diet, right? And then they report HCG works. And it worked, but not because of the HCG, it works because of the other treatment on the side. So a co-intervention means the patient getting other treatments. And you have to ask yourself, well, sometimes people write up papers and they don't mention the co-intervention. Real sneakiness, right? They don't mention the co-intervention at all. They actually don't input it. And you think, good boy. And all the time they got other treatments on the side which help them to meet the outcome, right? So all these are possible sources of bias for randomized control trial. Contamination, right? So actually we'll go through them because actually we just count, right? So when the outcomes we look at in a study, step 4 in a trial, remember you say there are 5 steps. You always have to ask, are the outcomes reasonable? What kind of outcomes we actually looking at? And it could be disease oriented. I'll give you a good example of this. This is an example I always give. I remember when I became an intern working in Port Spain General Medicine, internal med, chronic disease clinic, writing prescriptions for patients. Drug rep come ask to see you. Like, you know, drug rep never asked to see me before. All of a sudden, drug rep want to see me. It's because you have prescription writing abilities now. So the drug rep comes and say, Doc, I want to talk to you about our blood pressure drug. I say, all right, let me hear. You say, well, you should give all your patients this drug. Patients should be on this medicine. What medicine is that? Is an ARB, right? I think it was actually Pandasatan. You know Pandasatan, Atapan? Yeah. So she was trying to come into it. Give all the patients this one is the best. So well, why? Why is the best? You know, patients getting all of them to pull out the chart. Back then, they had no tablets. I think back then was flip charts. You know, she pulled out a flip chart, showed me thing, and I was like, okay. And what she said patients who get an ARB have less LVH, left ventricular hypertrophy, compared to all the other drug classes. Show me how the chart is true. I say, well, okay. So what do you think about that? The study she showed looked at LVH as the outcome. And the study did show that patients who got the Atacan did have reductions in LVH, more compared to the other group. So what do you do now? What you'll prescribe? You switch all your patients to ARBs? Assuming the dispensary have all. Assume the population similar to ours. Would you now prescribe? What about other outcomes? Exactly. Why we treat hypertension? What's the outcomes you want to prevent and treat in hypertension? MI, stroke, renal failure, heart failure, aneurysms. Remember, the big reason to treat MI is because there's overwhelming evidence that lowering blood pressure reduces all those outcomes. Suppose I told you those outcomes were all the other popular blood pressure groups, the ACEs, the CCBs, the diuretics, regardless of the drug class, once your blood pressure was reduced, would it make a difference which one patients get? No, it wouldn't. So that was a good example of a disease-oriented outcome. LVH. Yeah, LVH is important. Having a fat-swollen heart muscle is not good, is not healthy. But suppose the mortality rates and the admission rates to hospital is the same regardless of which drug you get. Then to me, it don't make. So that was a good example of a disease-oriented outcome versus a patient-oriented outcome. Disease-oriented outcomes usually do convenient to measure. Suppose I have to do a RCT to test whether or not a blood pressure treatment works. What will be the outcome in that study? High or low blood pressure? That's easy to measure, right? I give you a blood pressure drug. Within a week, I should see the effects. I just have to measure your blood pressure. So that's a disease-oriented outcome. What will be the patient-oriented outcome in treating a patient with blood pressure? Exactly, if a person died or get any of these conditions. But how long it takes to see that to happen? How long a person will have to be on a blood pressure drug to appreciate that did not get heart attack and strokes? Yes, exactly. So sometimes disease-oriented outcomes are used as a proxy, indirect measure, right? So disease-oriented outcomes are bad, but they just have that limitation and that it doesn't always translate into long-term benefits, right? You all probably know about the HPV vaccine. You all know there's a HPV vaccine, a vaccine to prevent cervical cancer. What they look at in those studies, they look to see if girls who got the vaccines had less of this condition. They use this condition as the outcome. What do you think is the outcome they use in this study? The studies that test HPV cancer. Not cervical cancer. Not cervical cancer, because it will be unethical to give people a vaccine and wait to the point they get cancer. So what they use is the cancer precursor, CIN. So most of the studies that look at HPV vaccine use CIN3 as the outcome. As a patient-oriented outcome or disease-oriented outcome. If you tell a patient, well, we see less CIN3 in people who get the vaccine, the patient might be like, well, I have no clue, is that CIN3 was that? I don't know what you're talking about. But sometimes we cannot do studies where the outcome is patient-oriented, right? So just keep in mind, when we go into the appraisals next week, and we look at the outcomes, the people that we study, ask yourself, what kind of outcomes to look at in this study? Was it patient-oriented or disease-oriented? Both important. And beneficial effects or adverse effects. When we test a new drug, we want to know if a drug making people sick, right? You see all the ads on TV. If you take this drug, if you go blind, if you lose a hearing, if you feel suicidal, be sure to go and see your doctor, right? So if you give a person a new drug, you always want to know if it's going to produce bad effects, right? So these are the outcomes you're interested in, which is patient-oriented and beneficial versus adverse. Blinding, what's the thing called blinding? You all know about this. Blinding, single blind. Single blind means what? The patient don't know what they're getting. Double blind means patient doesn't know what they're getting and the researcher. Which researcher? The researcher who has to determine outcome. The researcher who has to come up now and see. So if you're treating a hypertension, you have to come. The person who has to measure the blood pressure, who will know if you're controlled or not, should not know which treatment they're getting. Right? That researcher. That's what means the patient don't know what they're getting, the researcher assessing outcomes doesn't know what the patient getting, and the person doing the analysis don't know. So all he's seeing is group 1 and group 2 on his computer. He don't know if group C. Now at some point in time somebody has to know, right? Otherwise you study. So everybody can be blind, right? Because then we wouldn't have no results. We would know if the drug works. We would know. So it takes several people to do a randomized controlled trial. That's the point I'm making. Usually there are several research tasks with different rules to ensure blindness. The gold standard study is the triple blind randomized controlled trial. Lots of them triple blind and appeared in literature like within the last 10 to 15 years. Most studies would be double blind. If the people knew what they're getting, because sometimes it's impossible to blind. If the treatment I was recommending and the comparison was yoga or meditation. Maybe just say we do a trial with that to see if it'll help people with arthritis. You can blind a person to exercise. If you tell them, here, what a way to join this gym. You need to exercise so many times a week. You need to wear this accelerometer so we can monitor your physical activity. The person already know you're prescribing exercise and you can blind them to that. It's not like you can give a pill and sugarcoat it and say, take this tablet, and the person don't know what the tablet is. So when a study know the treatment they get, and what we call that? We call it open label. So open label means no blinding at all. An open label study is prone to lots of bias because the patient kind of like know what they get. So they kind of expect or thinking this could work or this wouldn't. Right? So let's keep that in mind. In terms of the analysis, the way we could do the analysis is a few ways. We could do this thing called intention to treat, which I'll talk about a little bit for you all. We could also do a per protocol analysis, and we could use these effect measures. So I'll probably ask that to jot down these abbreviations now to make sense of them, because we have to make sense of them in a bit. And this is CER, which is the control event rate. Right? That's what CER is, the control event rate. EER is the experimental event rate. RR is the relative risk. Triple R is the risk reduction. ARR is the absolute risk reduction. NNT, people know this one? NNT is numbers needed to treat, that's right. And we'll see what these other terms mean. Precision, subgroup analysis, we'll see what those mean. So the first one I'll take, so we'll come back to those abbreviations. The first one I'll mention is this one called intention to treat. As the word suggests, intention to treat means analyze people according to the group they were randomized to. Right? The other way they say intention to treat to describe it is they say analyze as randomized. And what that means, if you take a group of people, you randomize a group of people to placebo, you randomize a group of people to treatment, they're going to get analyzed according to how you randomize them. Even if the people who you sent to the treatment did not take any of the treatment, even if they crossed over, even if they were lost to follow. Does that make sense? group of people, you randomize them to treatment, and you had some people who never take the treatment at all, 100% non-compliant. You had some people who crossed over to the other arm, the placebo arm. You had some people who drop out from the study, say goodbye, me and we won't see you again. And what we're saying is you're analyzing them as though they got the treatment. That makes sense? But that is what intention to treat analysis says they should do. And this is the reason why. So look at this. We have 2,000 people. Put them up into two groups. One got control, the other one got intervention. Look at in the control group. 30 people lost. We don't know what happened to them. They say goodbye, they are coming back. So we left with 970. Out of this 970, 35 of them died. So if I ask you, well, what's the death rate in this group? You could work it out, 35 over 970, 3.6%, right? So in the control group, 3.6% of the people died. In the intervention group, it was 1,000 persons as well. And on and do always have to be exact numbers in each group. What is more important is the percentage, right? So even if in this group we had 900 people and this group we had 1,000 people, that is not really such a horrible bad thing. Generally in trials, they try to get it kind of be close, very close and even. Don't have to be exact. Because at the end of the day, the proportion you work out would still be what matters the most. But in this case, we also have 1,000 people get a treatment. 40 of them drop out. We don't know what happened to them. So we left with 960. And out of this 960, so then it work out the rate here, and 20 over 960 is 2.1%. So which group you think can better based on the death rates? Remember reporting death rates. Which group seems better? Intervention, right? So the intervention have less deaths compared to control. So you might say, well, yeah, this intervention working good. But intention to treat analysis says you cannot forget about the people who were lost to follow-up. Suppose they died. We don't know. Suppose the people in the control, right? And this is a suppose. Suppose the 30 of them who were lost all survived. Right? We assuming, right? We assuming. Suppose the 30 of them who were lost all survived. Then what we would say is 35 people died out of 1,000. So we get 3.5%. Didn't really change much. Suppose now in the intervention, we assume the 40 people, suppose we assume all of them died. It's an assumption. It's an extreme assumption, but suppose. Then now we have to say 20 plus the 40 who were lost is 60. And now it's 60 out of 1,000. So look at the event rates now. 6% of the intervention people have died, and 3.5% of the controls have died. So now which treatment better? Control seems better. So how we could get to different results? We got two different results. But in this case, we did what we call a whole protocol analysis. You only look at the people who come back. But intention to treat says one of the ways you could look at the results is assume the best possible scenario in the controls and assume the worst possible scenario in the treatment. Right? So what intention to treat analysis does, it underestimates the effect of treatment. And if the underestimated effect of treatment, still better than good faith that the treatment actually makes a difference. If when you do your protocol analysis, though, you get results like this, and when you do your intention to treat analysis, making the assumptions we just mentioned, you get results that are this, that are opposite, then it should really make you question the results. You should really question, well, hey, these dropouts could have really affected the results of the trial. Because what we say is you can't assume. You can't assume that the people who were lost, good and well. So this way of doing the intention to treat analysis is what we call an extreme case analysis. Extreme case means they assume the worst, right, in the treatment. There are different ways and different combinations of doing it. You could assume here that these 30 people died and assume here that these 40 people died. You could assume that these 30 people survived and these 40 people survived. You could assume that these people died, but these people survived and vice versa. So there are different combinations and ways you could actually work it. And what researchers actually do, and if all the results say the same thing, the treatment better than placebo, then you have good faith in thinking, hey, this treatment really working. But if the results sometimes disparate, they're different, then it means the assumptions you make really affecting the results of the trial, and your dropouts could have affected the results of the trial. Right? So in a nutshell, that's what intention to treat says. So intention to treat analysis is a good thing. You want to do it. If you see intention to treat analysis on a trial, the researcher is doing the correct thing. I'll pause here and just check in. Anyone confused by that? I know sometimes it's kind of hard to wrap your head around it. If you look at the maths and the values that you see in here, not too bad. I think it might come up in the appraisals when we do group appraisals from next week. All right, so any questions about anything so far? Well, you tell me. Which one you will see? Yeah. If you did this, yeah, you'll get. But then if you do this, you'll give the control. In other words, or you would not give the intervention, you would hold it. You'll say there's a chance this can make people bad. So what you'll do? What do you think we should do? Maybe a next study, that's right. So you should probably do a next study, and you probably can't practice medicine based on one trial like this. Right? So that's exactly what would happen. Yeah, that's right, exactly. Now, suppose it was just 3 people that was lost there. Instead of 30 and 40. We could do the same calculations, making the same assumptions, and probably it might not make much of a difference. Right? It would still show the treatment working because the number of people who were lost to follow-up was so small. Right? But intention to treat analysis is really what we call a sensitivity analysis. A sensitivity analysis is really when we make certain assumptions and we want to test to see if those assumptions could influence the results in different combinations. Right? Something good. You want to see it, you want to use it. Hopefully, an example, hopefully one of the appraisals next week have it and we know how to use it. But this is the idea. So it's a good thing. Now, right, so intention to treat, right? So this is what we see. Right? So this is really what we see it is. Per protocol, this is just looking at the people who come back, right? Subgroup analyses. Anytime you see the phrase subgroup analyses, stop reading. Well, the exception is this slide. They could read after subgroup analysis the rest of the slide. But subgroup analysis and the people stop reading because what comes after, chances are, is biased. When we say subgroup analysis, it's just that. It means researchers, when they conduct a big trial, a big study, they report not on the 2 big groups, but on subgroups. So you do a big study to see if a cholesterol treatment works better than the next cholesterol treatment to prevent heart attacks or strokes. And then in the findings, when you report only on diabetic less than 40 years. And you want to know why it is the only reporting in diabetic men less than 40 that the treatment works. The study didn't look at only diabetic men less than 40 years. The study looked at everybody. What they did is they did a subgroup analysis. And that subgroup analysis is guess what? It showed the treatment works for that group of people. And they published that. The drug worked. Everybody take it. So the problem with the subgroup analysis is it could produce findings out of pure chance. Anytime I say a subgroup analysis, findings, so it could be that is not necessarily true. What you should do, if you see a subgroup analysis showing findings, is they would usually design a randomized controlled trial to see that group of people if it really makes a difference. And sometimes it turns out not to be, right? So subgroup analysis is usually prone to misleading results, right? This is how we'll make sense out of the abbreviations we just wrote down. So probably you could copy this, draw this little table, because it'll allow us to make sense out of the abbreviation. CR, ER, you know, that kind of thing. Right? So, yeah. What I would say is in this case, the left-hand column, the Yes and no. Yes is something bad. Yes is to the outcome we're trying to prevent. So if we look at outcome and either the patient survived or the patient died, yes is the patient died, right? Is the outcome we're trying to prevent. Because if you notice, most of the words that we're talking about is risk. And when we talk about risk, relative risk, absolute risk, relative risk reduction, risk is the chance of something bad happening. So ideally, when you work out these, work it out for the event you're trying to prevent when we work out these measures, right? So if in a study, let me just say, we're looking at a group of people, 80 people lived and 20 people died in the treatment arm of a study, what we're focusing on is the death rate, not the survival rate. The survival rate is 80%, the death rate is 20%, what we're focusing on is the bad thing. That is ideal, because all these things talk about risk. Right, so so we could probably go into an example here, right? And we'll see what the words mean. So I'll just come out a presenter view and I'll see if I can make this a little bit bigger, right? And what we'll do, we'll actually try some numbers, right? And we'll go through the measures and we'll see how to make sense out of it. So suppose I say P was 10. Well, I should put P equal 10, right? Leave the numbers for you. And R equals, right? And suppose I say control now had, control had 40 people and S was 60. So 100 people in two groups. Intervention was 100 people control. And let me just say the outcome we looked at was if the person died, right? So the outcome was death, right? So we know the outcome is death. Where's Y? How much Y is? Question? 10 over 100. So 10 over 100 is 10%. You'll agree? 10 over 100 is 10%, which is also 0.1. You'll agree? Good. Don't tell me 10% is 10. If you tell me that, I'll send you back in primary school. Right? Because somebody going to make a mistake and they're going to put 10% as 10. And when you do that, you'll get an incorrect answer as when you work it out. Right? So remember your percentages, what they mean. So this 10%, right? Or kind of like coming down anything. But 10%, right? Or we could put 0.1. Right? So what I'll do, let me keep it as percent. So I'll put 10%. Right? So this is 10%. I'm trying to make it a little smaller. Right, so it fit, right? How you get that? 40 over the total. All right, so 40%. Right? So then X is 40%. So what these are simply event rates. Right? They are simply event rates. So Y is called your EER, the experimental event rate. That's what Y is. Right? So Y is the X rate. That's what it is. Right? Because as in the intervention, people got the treatment, how much did people die? And similarly, in the controls, X is the same thing as the control event rate. The control event rate is simply how much people in the controls died, or the outcome of interest. Right? So the question is what we do with these values. Before we do anything with these two measures, right? So I'll also put here, if it could fit, this as the E. And this one is also the same as the CER, right? So that's what we say, right? So what we do is these values. Now, these are death rates. So the death rates in the control is 40%. The death rates in the people who get treatment is 10%. Which treatment better? Intervention. Why is it so? Less people die. Perfect. Simple reasoning, right? That's simple reasoning. Look at it, less people die. So you're thinking this drug probably works. All right? You could think, you can't say for sure as yet, but you're thinking at least it works. So what we could do is work out this thing called relative risk. Relative risk is one divided by the other. It's the experimental event rate over the control event rate. So if we divide that, what we get? What's the relative risk? 10% over 40%, which is 5, right? Which is the same as 25%. That's 25%, right? Now, if the event rates in both groups were the same, what I would mean? You'll get 100%. So if the event rates in both groups were the same, let me just say here it worked out to 10% and here it also worked out to 10%. If you divide by 10 by 10, you're going to get 1. So a relative risk of 1 means there is no difference between the groups. I don't want to get from this calculation. Keep that in your head. A relative risk of 1 means the event rates in both groups were the same. In this case, is the event rate less than 1 or more than 1? Less than 1. So in this example, it's less than 1. The outcome was reported on something good or something bad? Something bad, reported on death rates, not survival rates. So anytime the relative risk is less than 1 and you're reporting on something bad, then you're already the treatment was better than the control. Now, if the relative risk was more than 1, what would have meant? If it was more than 1, then it would have meant that this rate here is more than this rate here. In other words, the intervention is harming people. The intervention making people sick. Again, that's if the outcome is something bad, right? So as we see in this case, the outcome was death. Right, everybody follow so far? Not confusing. The next thing we can measure is this thing called the absolute risk reduction. Now, what we just did with the two event rates, we divide one by the other. The absolute risk reduction is 1 minus the other. So if we take X and minus Y, what we get? We get 30%. 0.3, right? 30%, right? After equal to 10, which is equal, right? So that is the absolute risk reduction. Again, if the event rates were the same, the absolute risk reduction would have been 0. Perfect. So anytime we get a relative risk of 1 or absolute risk reduction of 0, it means no effect. Relative risk is 1 divided by the other, so the null value for that would always be 1. And absolute risk reduction is 1 minus the other, so the value will always be 0. Right? So keep that in mind. We will always come back to that. Now, there's another thing that you can measure here called the relative risk reduction. So what's the relative risk reduction? The relative risk reduction is the difference, right? Is the difference, and we already see the difference. X minus Y was X minus Y. The absolute risk reduction, we just worked that out. So it's equal to 0.3 over, which is the baseline risk, which is 0.4. So 0.3 over 0.4, which is equal to 0.75. Right? So now we have a few measures here on this slide. We have the relative risk of 0.25, the absolute risk reduction of 0.3, and the relative risk reduction of 0.75. Now, the other thing that we will measure or look at is this thing called the, let me just jump forward to the slide, this thing NT, numbers needed to treat. So numbers needed to treat is, what it is the number of people we need to treat to prevent one person from meeting the outcome we're trying to prevent. So if the NNT is 5, it means for every 5 people we treat, we'll stop one person from dying if the outcome of interest was that. Right? If the outcome we're looking at was people blood pressure, now you had a blood pressure drug, either it was controlled or not controlled. If we had to work on the relative risk for that, we'd look at the relative risk for people who were uncontrolled, right? And if you got the NNT to be 50, it means for every 50 people we treat, we'll stop one person from being uncontrolled. Numbers need to treat as a simple metric. It tells us how much people we need to treat to prevent one additional outcome from occurring, right? So simple thing. And how we work that out is 1 divided by the absolute rate over the control event rate minus the experimental event rate. Remember the absolute risk reduction, we just worked out the absolute risk reduction. In this case, it was, where it is? It hidden in the slide? Yeah, it hidden in the slide. Absolute risk reduction was 0.3. So if we had to work out the numbers needed to treat, then the numbers needed to treat would be 1 over 0.3, which is equal to about 3. right? So that's the numbers needed to treat. So what this means is for every 3 persons I give this intervention to, I would stop 1 person from dying. Simple. How much people we need to treat to stop or prevent one of the adverse outcomes we're looking at, right? So that's the numbers needed to treat. So does the numbers needed to treat better if it's low or if it's high? If the numbers needed to treat as 1,000, that good? No, that's bad. Because you don't want to treat 1,000 people to stop 1 person from dying. Do we ever do that? Do we ever treat 1,000 people to stop 1 person from dying? Really? We don't? Never, ever, ever? It depends on what the treatment is. It depends on what it is we're looking at. Breast cancer screening have shown that we need to treat on average about 500 to 900 women, treat with a mammogram, do a mammogram, before we could stop 1 lady from. Think that's good? It's good? Yeah? Yeah? So we do 1,000 mammograms to stop 1 lady from dying from breast cancer. Fair enough.
How much mammograms cost? 900 people.
And you have to do the screening over a period of time. You have to do it over 7 to 10 years. So the question, the reason why I just use that is it's not set in stone what is a good NNT. It depends on what the outcome is. We might treat hundreds of people with an intervention if the outcome we're trying to promote to prevent is death. Right? So always think about it. Always ask yourself, how much people it is we treated and was this cost and, you know, is it worth it? Was the outcome we're trying to prevent? Right? So the numbers needed to treat for screening for breast cancer, actually for women 50 to 70, that whole big chunk, that group is really about 500 to 900. That number goes up to about 2,000 if you look at women only in the 40s. So if you do screening mammograms in women only in the 40s, you need to do probably about 2,000 mammograms to stop or prevent 1 lady from dying from breast cancer. Right? So it's a good statistic because NNTs help you to kind of appreciate how much costs, and it also allows you to appreciate how effective our intervention is. When I send a lady for a mammogram, I tell her, I say, chances I'm not going to show any abnormality, and then we'll come back and tell you this was a cancer, and then we'll take out the cancer, and then we'll tell you we stopped you from dying from breast cancer. The chance of that happening is 1 in 500 to 1,000. I've only did a mammogram once on a lady, and it came back abnormal. It was a routine mammogram, it was screening. Not symptoms, and the lady said, Dr. Fine along. Screening mammogram, and it showed the abnormality. We send the patient for treatment, and now today she's cancer free. That's out of the hundreds of mammograms I've ordered in my entire career. Just 1. So the absolute benefit in it is small, right? So generally in medicine, we don't like treatments. Just one clinic I had our postgrad family medicine students, a lady came complaining of dizziness, right? When she said, Doc, dizziness takes me feeling bad, the whole room spinning. When I lie on my right side, God is real bad. When I lie on my left side, I'm good. The lady, typical history, the lady, classic description. She described BPPV. So we did Epley's maneuver, immediately better. So I told my postgrad, the NNT for the Epley's maneuver and preventing patients from experiencing vertigo is 2. You don't get better than that. I remember once one of some of my undergrads complained, they work out the NNT, it was 2. They say, 2, that bad. I was like, what better you want than 2? After 2 is 1. You know? After 2 is 1. So I was like, that is real good. You don't see interventions in medicine with NNT so small. Right? So just to give you a right? So, so when we analyze the results, this is really what we were seeing. The relative risk is 1. It means 1 treatment not better than the other. If the relative risk is less than 1 or more than 1, then you have to look at the event rates. You know one better than the other. And then just look at the event rates to see which one. In this case, we're reporting something bad. In the treatment, the event rate was less than the control. So you already know the intervention working. If we had reported on something good, if we had reported on survival, and in people who got treatment, the survival rate was 10%, and people who got control, the survival rate is 40%. And clearly, which one better? The control, exactly. So to interpret relative risk, you always have to ask which one they divide by which, and what was the outcome that they were looking at. Now, the other thing I will highlight in this calculation is the outcome. For this calculation to work, the outcome have to be dichotomous. Dichotomous means there's only two possibilities, yes or no, right? Sometimes we treat people and the outcome isn't something simply dichotomous, the outcome is a value. So you might treat a person for anemia and the outcome might be the HB, the hemoglobin level. Hemoglobin is not yes, no. You might say yes, no if you pick a cut point for anemia, right? So this whole calculation that we use assumes the outcome is dichotomous, right? The other thing this calculation assumes is that you compare an intervention to a control, to placebo. Often, what I would say at this point, when we do trials in medicine, we don't compare treatment against control. We compare treatment against treatment. If a new blood pressure drug come out this day and age, we can't take a group of people, what kind of patients? Uncontrolled hypertension, and randomize a group to say, you take nothing, and then randomize a group to the new drug. That'll be unethical. So what we do, we randomize a group to existing treatment plus nothing, and then we randomize the other treatment plus the new treatment we're interested in. So two groups get treatments, right? So it's unethical to compare to placebo when there are existing standards of care. Most studies now actually don't compare treatment against placebo because so much RCTs has been done, and we already know it have existing treatments for a lot of the conditions. Only if somebody kind of like develop a new cancer drug and there's no existing treatments for that cancer, you know, then they would say. Often is the intervention existing standard of control. So if you compare a treatment against a treatment, then which one you divide by which? If I told you this was drug A and drug B, then how you work out the relative risk? It don't make a difference. The assignment of which and which is arbitrary. It really don't make a difference which, right? It makes sense actually for the control to label the control as the one with the higher number. That's generally what they would do. They would call the control event rate the one with the more people. Right? That's generally what they do. But as we'll see in the forum examples, if you compare a treatment against another treatment, it do make a difference exactly how you divide it. Right? So if we compare a treatment against another treatment here, you could say 10 over 40, you get 0.25, or you could say 40 over 10, you get 4. The numbers say the same thing. Right? Saying one group got 25% times as sick as the other group is the same thing as saying the other group got 4 times as sick as this group. Right? Same thing. So always go back and look at the event rates to see, right? So at this point in time, what it is I want you all to do, because there's something I want you to kind of like get, is I want you all to work out this example. So look at this example, right? You have a randomized control trial on 100 patients. 50 patients get this thing, RTPA. 50 patients receive placebo, right? So in this case, there's an intervention and a control. Right, so 50 patients group A and 50 patients group B. So which one is control event? Is control. Which one is experiment? Placebo is control and group A is experimental event rate. So 50-50 in each. That's the only thing you need to take from this. 50 in each group. Group A get the treatment, RTPA. Group B get placebo. That's where I write it down. Right? Everybody have that? Group A, RTPA, 50 people. Group B, 50 people control. In group A, 20 people die, while in group B, 5 people die. So what it is I want you all to do is draw that same table we just copied, right? You could probably draw over a new one because we just, you probably just write away, put in numbers in the one we just had. We're drawing over this table just, this one, right? We're drawing over this table. What it is you're doing, you're working out all these things. The control event rate, the experimental event rate, the relative risk reduction, the absolute risk reduction. Right? That is what we're doing. So you all have this information. The only thing on this you really need to write down is in group A, 20 people die, and in group B, 5 people die. Yeah? You all have that? Yeah? I'm going back to the table and I'm going to undo all the writing if I could. I undo the writing. I probably have to come. these are the measures we're working on. So essentially, you're drawing this table. Let me take out these. Right, and we're working it out. Right, and of course, we're working it out for the outcome being that. Right, as we're working it out. So to label it up, I'll label it up in the table to give you a kick start. The intervention is what, group A? Group A, yeah. I'll leave it on the spot. I've seen calculators and things out, man. Yeah. Speaking of which, you get calculations at the end there, this thing. So I'm telling you all from before, you have to get calculators, can't use your phone. Last emergency medicine class, they complain, they say I make them buy a calculator. Right? Nobody uses that thing again on your phone, right? They say I make them buy calculators for the exam. So, yeah, calculate. This one? This one?
Yeah.
I've seen plenty calculating going on. I've seen 5 calculators out, you know? Yeah, they're auditing. Yeah, they're auditing. Yeah. Right, so any answers coming up? Any answers coming up so far? So let me start filling in this table. Right, so what P, where's P? P was 20. So that means R was 30. Q was 5. So that means S was 45, correct? So if we have to work out the experimental event rate here, it would be 0.4, 20 over 50, which is 40%, right? 0.4, correct? The control event rate here, it will be 0.1, 5 over 50, which is 0.1. So looking at that, if 40% of the intervention people died, and 10% of the control died, you're already seeing, what are you seeing? More people dying in intervention. So this intervention harming people and making people sick. So here the relative risk going to be. What that means, it means there's 4 times as much death in the intervention group compared to the control, which is horrible. You know, that's really horrible. The intervention killing people and making people sick. You know, don't get people in at all. They're better off giving nothing, right? And making people sick. What's the absolute risk reduction? Minus 0.3. So how you get that? 0.1 minus 0.4. So when you get a negative absolute risk reduction, in this case, it makes you think what's harming people. Because certain people are making them sick. Now, in this same case, what we have to do, as we have the absolute risk reduction, we could also calculate the numbers needed to treat, because that is simply 1 divided by the absolute risk reduction. And the absolute risk reduction was minus 0.3. So 1 over minus 0.3 is minus 3, about. So what I mean? 1 negative number and 3 mean. Oh, yeah, minus. Don't treat people. Don't treat them, yeah. So it's a negative NNT is actually a number is needed to kill. I like that. A NNK or a NNH numbers needed to harm. Right? So if you ever get a negative NNT, right, and the outcome was something bad, it is actually. So, which we kind of like know. It means for every 3 people treated, 1 would die. Yeah? That's what it actually means. 1 would die. You wouldn't prevent that, you would cause that. Right? So that's the interpretation. So I'll do this one on purpose just to emphasize to you all that, I mean, you would hope that generally when we publish research, most of the time the treatment will be better than placebos. And not the next way around, the placebo will be better than treatment. Actually, you call studies like this negative studies. Negative studies are people. And actually, journals don't want to publish it. There's that bias. Journals don't want to publish negative studies. Actually, not because it's unethical, but I mean, it just doesn't look good. I mean, you test a treatment and it make people more sick. That's horrible, man. Exactly. So people will know not to give the treatment. Exactly. Now, negative studies are actually studies where there was no difference. So sometimes they call negative studies where the event rate and experiment rate was the same number. That's what they call a negative study. This kind of study, I don't know what they'll call it. If it will be a negative study, I don't know what they'll call it. But generally, researchers, journals don't want to publish studies like this. If we were to work out the relative risk reduction, we'll also get a negative number because the absolute risk reduction, which is in the numerator, is negative. Right? I mean, you could work it out for working out sake, and we'll get what? Minus 4.5, how you get that? So we get what? Minus 0.3 minus 0.3 over 0.1, right? Which is minus 3. Yeah, again. So you get a negative number because the drug actually hurting people. The drugs actually harming people, right? So, I mean, that is how you do the calculation. What I would say though is we saw a relative risk of 4. In the other case we just worked out here on the slide, we saw a relative risk of 0.25. You would never ever see a relative risk as a number by itself. You would always see it reported with something else, right? So all these values we see here, minus 0.3, minus 3, minus 3 here, all these values are incomplete. You would never see a relative risk. You would never see a relative risk 0.25 in the story. You would always see something else in addition. So that's the next thing I'll be talking about, right? Before I say that though, look at the study. This was a study called the FIT trial. The FIT trial was one of these studies that showed, you know bisphosphonates It's drugs that we use to strengthen bones to prevent osteoporosis. So this was one of the earlier bisphosphonate studies. And it was a study on alendronate and what it did, the outcome they looked at fractures. So this was a multi-center trial. They looked at multiple groups all over the US, I believe. And to enter the study, the inclusion criteria was they had to have weak bones, right? A bone mineral density, maybe a DEXA scan showing a T-score minus 0.25, whatever, however they mention it. And they might have had a previous evidence of vertebral fracture. They looked at the effect of alendronate in preventing a fracture at the hip, at the femoral neck. And this was the results. The reduction of hip fracture % after 6 months of follow-up. What I mean to you, I should put quote and unquote because that's actually the statement from the trial when it was reported. What I mean? How you'll interpret that? Was that? Well, that's why I want to know how you will interpret that statement. All right, you need more information. Group got which and was the event rates in each, right? But if you have to look at this statement, would anyone interpret it that way or ask for more information? How we look at that? If you have to explain that to a patient.
I assume
And what I mean? If you have 100 people, so 50% of people get a fracture. That's what you say it?
No.
What do you say? Okay. So if you have to explain that to a patient, how you'll explain it? If the patient wants to know how much benefit I get from this drug if I use it, based on that statement, you could say, can you say? So I'm happy you asked for more information because that's really what you would need. But to unsuspecting people who don't do EBM, what would happen is they would read that and they would interpret it as if 100 people take the drug, 51 out of 100 people not going to get fractures. That's how some people will interpret it, which is the wrong interpretation. Because it's a reduction. What kind of reduction? You'll know about two kinds of reduction. Ups. Open and close. I know you know open and close. Somebody would have said that. I know you know open and close. Right? But in EBM speech, not orthopedic speech, reduction can be an absolute risk reduction or a relative risk reduction or a relative risk. I don't have reduction. So which one are you talking about? Which one do you think they're talking about out of the three measures we just worked out? Relative risk reduction, absolute risk reduction, or relative risk? Which one? Pick one. Anyone? Which one do you think they refer to? Relative risk? All right, so let me see. This was the results. This was the results from the FIT trial. So if you had to work out here, this is the control event rate. You're gonna say what? 22 over 1,005. So work out. How much you get? 22 over 1,005. That is what? About 2%? Yeah, about 2%. Yeah. Work it out. Tell me, Christy. 0.0, right? Yeah, exactly. 2%. And the intervention was 11 people getting a hip fracture out of 1,022, which is about close to 1%. Work it out and tell me. 0.01, exactly 0.7. So look at that. In the placebo, people who get nothing, 2% of them get fractures at the hip after 3 years. With the intervention group, 1% of them get fractures after the 3 years. How effective do you think this treatment is? Do you think this treatment very effective? You'll give your patient this treatment? It only changed it by 1%. Without the drug, 2 out of 100 people will get a hip fracture. With the drug, 1 out of 100 people will get a hip fracture. Was that? It'll help the one person. Help our one person. That's right. So this is what we just worked out. 2% is the control event rate. 1% is the experimental event rate. What we could do with those two values now, we could work out all the measures. So relative risk is 1% over 2.1 is 49%. Relative risk reduction is the difference over the baseline risk, 2 minus 1 over 2, which is 51%. That is what they mentioned. So what they quoted was a relative risk reduction. Also work out we'll work it out, but this point that I'm making here is that relative risk reductions could be sometimes big numbers, as in this case. And researchers like to use it and report on findings because it gives the impression that the treatment really working. Whereas it's not really a good measure by itself. You can look at the relative risk reduction alone and gauge if a treatment is worth giving, right? Same thing for relative risk, right? In this case, the relative risk reduction, see big 49%, 51%, but benefit is small. The absolute risk reduction will be the difference between the two, 2% minus 1%, which is about 1%. And what we could work out from the ARR, numbers needed to treat, 1 over 1.01% is 90. So what this means is we need to treat 90 persons with alendronate every day, daily, for a year, by 3 years, to stop 1 hip fracture from occurring. Cindy shaking her head. You don't know who the one person might be, right? You don't know, you don't know, you don't know, and it's expensive. So one of the other things that could work out based on the NNT is something called the COPE statistic, the cost of preventing an event. So if we knew the price of one alendronate tablet, we could work out 90 times the cost of an alendronate tablet times the amount of days in 3 years, and we will get the cost of almost $1 million that we would spend in given to prevent 1 hip fracture. Would you do that? Would you spend $1 million giving women alendronate to stop 1 hip fracture? It depends on the cost of treating a hip fracture. Most correct. Suppose I told you Abigail it's more than $1 million to treat a hip fracture. You got out me, you say, nah, it can't be $1 million to put in a dynamic hip screw in somebody. The thing about it is, if you look at this in this kind of simplistic way, the cost of treating a patient is not only direct costs. So people actually work these things out, health economists, right? When they do disability and work out disability adjusted years, they work out the cost absorbed when this person gets a hip fracture. There's no only the cost for to put the patient in theater and to pay the anesthetist and the doctor, and the cost for the dynamic hip screw, and the cost to pay the consultant. Is the cost from the lady staying home from work and missing out? Is the cost from the lady not being able to go to the cinema and enjoy life and do things? Exactly, put a cost to these things, you know. I'm saying, yeah, exactly. So costs are direct and indirect. So it may actually be more than $1 million if you look at the cost of a hip fracture. So again, I'm not saying there's a right or wrong answer, but just saying when we have an intervention, it's always good to think about the intervention in terms of cost effectiveness. This is a very oversimplistic way of looking at cost effectiveness, but it gives an idea. I was part of a group a few years ago. They wanted a UWI person look, and they wanted to do a national cancer screening, right, for breast cancer. So what we did is we worked out the numbers needed to treat for breast cancer for screening, and we worked out how much money we have to spend just only in doing mammograms to prevent 1 lady from dying from breast cancer. And that cost came out to $2 million. We need to spend $2 million doing 500 mammograms in 500 women over a 7-year period to stop 1 lady from dying from breast cancer. The question is, I'm also part of a group recently with Dr. Maraj from surgery, Ravi Maraj, and they were looking at, they're still considering having a nationwide campaign to screen for colon cancer. And what they're considering using is FIT, because we don't have enough endoscopists to do colonoscopy in everyone. And what we realize is, even considering the number of people we need to screen to prevent colon cancer in the eligible age group, we would still need to do about 20,000 colonoscopies. And even that we don't seem to have the capacity to do because the amount of endoscopists that we have present and the need, right? Because if you do the FIT test, these 2 tests on patients, about 13% of them going to become positive. So if it's about 200,000 people and 13% of them becoming positive, that's how much people we have to do colonoscopy on, right? So you could use these things to kind of like help you make decisions and help inform policy and all these kind of things. So they do have some benefit to a certain extent, right? So these are 2 hypothetical studies, unrelated to the examples we looked at so far. Now that I know you all are experts in calculating this thing, I know you all could just watch the slide and you'll see the numbers jumping out. So first study, well, I'll show you the answer. First study, control event rate 50, experimental event rate 25. Where's the relative risk reduction? How we work it out? Relative risk reduction is the difference over the control event rate. So 50 minus 25 divided by 50 is 50. How about this study? This study B. 0.02 minus 0.01 is 0.01 over 0.02 will also give you 50. So as long as the control event rate is twice the experimental event rate, you're going to get a relative risk reduction of 50%. There's two studies, same relative risk reduction. What's the NNT for study E? 1 over the difference, 1 over 25%. 1 over is 4. Not good or bad? Not good, yeah. How about study B? 1 over the difference. The difference is 0.01%. 1 over 0.01% is plenty, right? 10,000. Which study better? A. A, right? Less is more, right? The smaller the entity, the better. So what this tells us is studies could sometimes have big or the same relative risk reductions, but the benefit from the treatment could still be very, very different. So if you see relative risk reductions by itself, which is what I showed you with the FIT trial, you have to ask for more information. So you're correct in asking for more information. I want to know the event rates. I want to know the NNT. I want to be able to calculate the relative risk, right? So this just kind of emphasizes that point. What I would say, so there's two things we have to say now and then we wrap up, right? We're close to the end. The two things I'll say is about this thing, a confidence interval. So what's this thing called a confidence interval? A confidence interval is a range of values. An interval is just a range of values. So if I tell you 1 to 10, that's an interval. If I tell you 100 to 1,000, that's an interval, right? So an interval is just a range of values. Where the word confidence comes in is how sure we are that about that range of value. And usually my standard is 95%. So a confidence interval is just a range of value, so that that range of value has a probability that it has a real value. And the real value we say, or the probability that it has a real value is 95%, right? It's called the confidence level. So I can give you an example. This again is a silly example, but kind of emphasizes the point. I could say, I don't know the exact age of everyone in this room. I don't know, I'm doubtful. But I'm 95% sure the age of everyone in this room is between 25 and 50. You understand? So what's the interval there? The interval is what? 25 to 50. And I'm saying I'm 95% sure the ages of everyone in this room lies within that range. So a confidence interval is a statement of doubt. It's saying I don't know for sure what's the exact or the real value. But it's still saying, providing a range and saying, but I'm kind of sure the real value lies within this range. The question is how we use that information and how it applies to a randomized control trial. So we'll go to an example. And this example is an interesting example. This example is, I think, actually one of your randomized control trials that I think the emergency med persons presenting in on next week is one related to this, tamsulosin and the treatment of kidney stones. You all know we can give Flomax to patients with low ureteric stones, right? Once I wrote Flomax for a female patient and the pharmacy called me and said, Doc, you mean Flamma MX? I was like, no, I don't mean Flamma MX. And I write it big bold, no. I know as a female patient, I write the diagnosis, ureteric calculi, kidney stones. So we could use tamsulosin, which of course we use to treat BPH in men. It dilates the ureter. If you have a distal ureteric stone, if it's less than a centimeter, it encourages you to pass it out. How we know that? We call it medical expulsive therapy for the treatment of kidney stone. How we know that? It's about treatment. We know that because of a randomized control trial. This was one of the earlier trials that. So they take a group of people, randomize them to placebo, and a group of people and randomize them to tamsulosin. And this is what they found. The chance of stone expulsion was 3 times higher in the tamsulosin group. Now note what they comment on. What they comment on? The chance of stone expulsion. That's a good thing or the bad thing? That's a good thing, exactly. So they could have worked out the chance of not expelling the stone, right? But what they worked out is the chance of expelling the stone, right? So keep in mind what the outcome was. And what they found, it was 3 times higher in the tamsulosin group compared to the placebo group. So if you see that 3 times higher, then you're thinking, well, this drug working. If people who get tamsulosin 3 times as likely to pass the stone out compared to people who get a placebo, and then this drug probably works. But here you see a confidence interval. So it tells you the relative risk is 2.93. And you see in a confidence interval of 1.2 to 7.5. My question to you is, how do you interpret that? If you had to look at this statement alone and make a determination on if this drug is worth prescribing or if you should prescribe it, what you would say? Any ideas, any thoughts? So what we're saying is, I'm not too sure is exactly 3 times patient more likely to pass the stone out in the tamsulosin group. If I were to repeat this study 100 times, but if I were to repeat the study 100 times, the second time I repeat the study, I will get a relative risk of maybe 4.9. The third time I may get a relative risk of 1.5. The fourth time I may get a relative risk of 4. Right? 95 out of 100 times, I would get a relative risk in this range. How we interpret that now? How we use that information? Remember earlier on we said if the relative risk is 1, it means same, no, right? So if the interval here includes the value 1, then you would say same, tamsulosin, no different than placebo. But does that interval include the value 1? 1.1, 1.3, 1.4, 1.5, keep going to 7.5. Would we include 1? No, 1 all the way before 1.2. So because it does not include 1, we say it is statistically significant. And that's the interpretation for relative risk. For relative risk confidence interval is, look at the range, ask yourself, does this range include the value 1? If it includes the value 1, you say, well, no difference between the treatments. If it does not include the value 1, you say, there is a difference. And then you actually have to look at the results to figure out where the difference is, which group better always. Right? Anyone confused by that? I'll say it again. To interpret relative risk confidence interval, you look at the range and ask yourself one question. Does the range include the value 1? The value 1, not statistically significant, not. If it does not include the value 1, if it excludes the value 1, statistically significant. The difference really exists. And you all can understand why, because we said it just now from our calculations, a relative risk of 1 means the event rates in both groups are the same, right? If you can just grasp that concept, you have interpreted half of the medical literature already. First big leap for EBM, because most of the literature value or a confidence interval, most literature that you would read, right? So you could interpret half of the medical literature already. What I would also say, we'll go into it later in the other weeks, but relative risk, odds ratio, hazards ratio, all these numbers and words is interpreted the same. If the confidence interval for these things, hazard ratio, odds ratio include the value 1, no significant difference. If it excludes the value 1, significant difference. So we'll see how to calculate those in week 5, but the interpretation is the same. Anyone lost? Anyone confused? You see? If it does not include 1, it's significant. And that is. That's what you want. That's what you want. Well, it depends on what you're comparing. And it depends on those 2 things you're looking at. Intervention and control. Now, suppose I told you we come up with a new blood pressure drug. And the existing group of patients is group A, they get a treatment, the blood pressure was controlled. And we compared to group B, the new group. And we found that the relative risk in one group compared to the other was 1.3, and the confidence interval was 0.5 to 2. It includes 1? Yeah. So that means there is no difference between, meaning the new drug is as good as the existing treatment. Yeah? So one wasn't better or worse than the other. So that is not such a bad thing. So that's how some treatments are described as being non-inferior. Mm-hmm.
Right, just because it's up, that's 1.
Yeah.
More on the...
It include 1. You want to sit? Why you want to sit on the fence for? Yeah, so you're correct. If it's 0.9 to 10, it include 1. So not statistically significant. That's the black and white interpretation I'll give you. right? That's the black and white interpretation I'll give you. I'll be devil's advocate and say if it was 1.01 to 10, what you'll see?
Yeah.
That's right, that's right, that's right. You're correct. But sometimes it helps the extremities of the confidence interval. If the extremity in the confidence interval is 1.01 or 0.99, to me that is 1. I would interpret that as it is statistically significant, but the effect the treatment having could be not really all that great, right? So it helps sometimes to look at the lower limit of the confidence interval and ask yourself how close it is to 1. So yes, this is definitely significant. So what this means on your worst day, on your worst solution, going to increase the risk of stone expulsion 1.2 times compared to placebo. Now you have to decide if that is acceptable for you and your patient. On your best day, tamsulosin going to increase the chance of stone expulsion as much as 8 times. So the other issue that comes up, confidence interval interpretation, is how close the limits are to 1 and the width of the confidence interval. And when we speak about the width of the confidence interval, that is referred to as precision. A more precise confidence interval is narrower. A less precise confidence interval is wide. So in this example here, the relative risk was 2.9, and I told you the confidence was 2.8 to 3. Then you would say that's a very precise confidence interval. The width was so small. Whereas in this case, you might say, well, this width kind of wide. It is statistically significant. Terminology coming up when you do the appraisal, what it's referring to. All right, so anyone confused or anyone confused? Anyone go over anything? Interpretations, right? They'll come up in the forums, right? So the forums is for everybody. The person who tagged will reply, but all this will come up in the forums to clarify conceptions, right? So,
with regards to the example we just had, right? So if the relative risk is more than 1, outcome is better than treatment, right? But that's only if you're
if the relative risk is more than 1,
right,
as in this case, but here it was reported on something beneficial.
right. Good.
So it was good. It's a good thing that in this case, the relative risk is more than 1. If they're reporting on something bad, then they would have said the chance of stone expulsion, the chance of not expelling the stone is 3 times higher in the tamsulosin group, and that would be bad. That would mean the drug actually stopping you from passing the stone out, right? Which is not a good thing. So you always have to look at the outcome that they reported on. Yeah, exactly. Yeah. Anything else before we close up with p-values as the last thing I have to say? No? Nothing else? No? All right. So what's this thing called p-values? P-values, where did the word p come from? Precision, it doesn't come from precision. Close. The last slide had precision. I wish it come from precision. It comes from probability, right? So it comes from probability. Where p-values come from? It's come from statistical tests. You run a statistical test, it generates a p-value for you. You look at the p-value, right? So they're calculated from statistical tests. Because it's probability, it could only lie between 0 and 1. It could be 0 at its worst, 100% at its best, right? So that is what a p-value is. And is the probability of what? The probability, the findings were due to chance. So if we stop back and just think about that phrase, tell you, whether man or whether girl, whatever you want to call them, say ITCC acting up, whatever, you know the crazy weather we get every so often. Today I actually made it a year. For the bad weather we had last year, it was on the 18th of October. I was doing this class online because people couldn't come to class. That's when the rain started actually falling, the 18th of October. I remember this well last year. So last year I wasn't doing this class in this class where we all did it from home. Everyone went because the rains was so bad it now started to fall. You know, the Great Vale and Kelly, yeah. Exactly a year ago. Well, I'm not saying that. I'm not saying that, you know, just drawing reference. But if the weatherman say there's a 60% chance of thunder showers, you think rain will fall? In Trinidad. Yes, in Trinidad. Yes, the Trinidadian weatherman or weather girl. Right? Siguni or whoever, one of them. What's yet? What you saying? What you saying? Will you carry an umbrella? If they say, I say they're correct, the opposite is happening. Most times. If they said there was a 20% chance rain would fall, what do you do? You walk with your umbrella? You do the opposite. Fair enough, you do the opposite. If they said there was a 90% chance rain would fall. So why it is most people said yes, they'll walk with their umbrella for 90? You think you more. Exactly. So the analogy I'm making with that and this in interpreting the p-values is we don't ask the chance that rain would fall in research. We ask the probability that the findings were due to chance. And we ask, what is acceptable for you? If we say the findings, the probability that the findings were due to chance was 20%, that's good for you? If we say it was 50% probability the findings were good, that's good for you? Be less. How much less? 5%. 5% is just the convention, the standard. So we call that the significance level. The significance level of 5% is just by a convention, as an arbitrary point. And there's 5% chance we're willing to take that the findings were due to chance. We say if the probability that the findings were due to chance is more than 5%, if it's 6%, if it's 5.1%, right, Vishma? If it's 10%, we say that's too high. So what we say is 5%. That's where we get a p-value of 0.05 from. Now you could set a p-value of significance level of 1%. You could say, well, I'm doing this new treatment and people could die if they get this treatment, or they could live if they get treatment. It's a real serious treatment. I'm going to set the significance level at 1%. I'm not going to accept anything more than 1% probability findings due to chance before I could say I prescribe this to people. Some they set the significance level lower. You could. There isn't any rule that says it has to be 5%. It's just the convention that everyone uses, right? So 5%. So how we use this is probability that the findings were due to chance. When we see a p-value, you're always doing what we call a hypothesis test. And the hypothesis is of usually two opposite varieties. The hypothesis is either you're doing the null hypothesis. The null hypothesis simply says null means null, zero. The null hypothesis says there is no difference or no associations in the groups. So the null hypothesis, if we were to test a treatment against another treatment, if we want to compare tamsulosin with placebo, the null hypothesis would be the chance of stone expulsion in both groups is the same. There is no difference in stone expulsion in both groups. That's the null hypothesis, right? The alternate hypothesis, though, is what we conclude if the p-value is less than 0.05. So if the p-value is less than 0.05, we say we reject the null hypothesis. Now, if the null hypothesis says there's no difference, and we reject the null hypothesis, then we say that a difference exists. And that is really anytime you see a p-value, what's going on. Anytime you see a p-value, a hypothesis is being tested, right? And you're looking to see if the p-value is less than 0.05, 0.05. If it's more than 0.05, what we say, the probability that the findings are due to chance, too high. Because we say 5% is our cutoff. And we say we can't reject the null hypothesis. So we have to say, well, the group's really not that different. They're similar, right? Now the question is how we interpret that in a real example. So this is an example. This study treated acne. They looked to see if people get an adapalene benzoyl peroxide gel, the combination, using, I think, adapalene only. Yes, adapalene only, right? So they compared dual therapy against a monotherapy. So the people who got the dual therapy, guess what? Everyone started off with acne. They saw less acne lesions than the people who got the dual therapy. P-value 0.001. So what do I mean? All you have to do, if you're zoned out for the last 2-3 minutes I was talking, all you have to do is ask yourself, is this less than 0.05? Yes. Statistically significant. Dual therapy is better than monotherapy. Literally put, there was a 1 in 1,000 possibility that the differences they saw in the trial where it had less acne lesions in the dual therapy versus monotherapy. There's a 1 in 1,000 probability that the finding was due to chance. But we say that is acceptable because we say it's less than 5%. So even a p-value is not something absolute. I could tell you the p-value is 0.000, I could count 5 zeros and then put a 1. There is always a possibility the finding was due to chance. You understand? But we say is less than 5%, which is our convention. That's the cut point. right? So that is it. This is another example, probably the same example I had from undergrads. The effect of Momodica Trantia. You'll have no clue with that. I had no clue with that. Momodica Trantia is Karaili. Right? You know Karaili? I hope you all know Karaili. Karaili or bitter melon, whatever you all want. Bitter thing. I don't know if you all have patients. I have patients said, Doc, when I ring that and drink it and eat it, my sugar is good on it. Oh, I see it. If you eat that, your sugar must go down. It's so bitter. Right? Karaili is the most bitter thing ever. It's like, wow, people eat this thing. Right? So they did a study and they wanted to see if people getting Karaili compared to people getting placebo if you could lower your sugar level. Makes sense? Because what they have shown is the Karaili and animal models has hypoglycemic properties. Right? So they decide to go a step up in the hierarchy of evidence. They decide to do a clinical trial, a randomized control trial. So guess what they found? They found the HbA1c was a little bit lower in the Karaili group. It was 0.2% less. Now you might say, well, 0.2% less than HbA1c. Our idea was 8.6 and you moved to 8.4. Yeah, no big difference, but it was less. We want to know when we see a difference, if that difference we see was significant. We see a p-value here. The p-value is 0.4825. What I mean? There's almost a 50%. You could flip a coin. There's almost a 1 in 2 chance that this difference was due to chance. Is it more than 0.05? Yeah. So we say, well, although we saw a difference, even if it was in favor of the Karaili, the difference was not statistically significant. So we do when patients ask us, we say, well, you could eat your Karaili, drink it, you know, do whatever, but you have to take your medicine too at the same time. That's what we were telling. Research hasn't shown that it significantly reduces your sugar level, at least not good enough. At least this piece of research, right? I would make a blanket statement like that. So that is now, with p-values, now you're able to interpret the other 50% of the medical. Most of what you all have to interpret for the rest of this course and the most of your careers would be either confidence interval or p-value. That is statistics interpretation in a nutshell. So I think, you know, now you have a idea how to approach it, right? So the critical appraisals, right? So we do them next week. All the groups, right? They assign. People on Moodle probably see who assigned to which, right? My approach for this, because it's the first time I combine the classes, is I give the family medicine people certain types of bits to present their appraisal on, and I give the emergency medicine bits, things that you all could relate to, right? So to keep it kind of interesting, even the forums, I give you all emergency medicine literature to interpret. Our family medicine people, I give them things maybe more pertinent to general practice, right? So both the forums and the appraisals have both elements to capture the two crowds.